started. Good morning, one and all. I wish to say that it's a huge joy and a privilege for us to meet here today. It's a joy and privilege for two reasons. First, because we have two colleagues, renowned specialists in reflections on public healthcare systems, not only in the United Kingdom, but elsewhere in the world. In addition, there are people who have been active with us in this area and made major contributions concerning financialization of health systems, especially in England, but not only in England. And also, it's a huge joy for us and a privilege to convene here today with all of these people from the health field. I want to thank you from the bottom of my heart, all the institutions, ABRES, Abrasco, Fiocruz, the Brazilian Association of Collective Health, the Ministry of Health. I don't know if the National School of Public Health, and all of the other institutions. If I forgot anybody, I apologize, because we're all convened here this morning to reflect on and debate the paths in public health systems for provision, not only health, but care in general, to reflect on the challenges that we have ahead of us. And I think that we're going to learn a lot this morning, hearing our colleagues, Jasmine and Kate. I would like to introduce them briefly. Jasmine is a professor, social scientist, associate professor at the University of Birkbeck, part of the University of London, and Kate Bayliss is an associate researcher at the Department of Economics at SOAS University, which is also part of the University of London in Sussex. I would just like to remind everyone quickly before I turn the floor over to our colleagues, and I want to thank Francisco Funcio for convening us this morning, the great effort and the funding provided by the Institute of Economics. We're honored to have this partnership, and I hope that it's the first of many events that we'll be holding together, because the situation is difficult here in Brazil. It's daunting, so we need more partnerships to face the challenges and tackle the challenges that we have ahead of us. I want to remind you of two things. First of all, I want to highlight the work that Kate has been conducting in this area of reflections on provision, healthcare provision. She wrote her last book. It's extremely important, not only the categories of the welfare state, and to work with another methodology, which is precisely this one, of provision systems, to understand the actors, the formats, and the funding, and different ways of attempting to learn and grasp the processes of restructuring underway in the healthcare provision, private and public systems. And in addition to which, she has numerous articles. I'm going to list all of them because it's a long list, because at the same time also I would like to remind everyone, Jasmine Gideon recently, she published a compendium, or an edited book, or an anthology with several different articles on the issue of public-private partnerships. Not only articles which question this from the theoretical point of view, but also a series of studies, parallel studies, which demonstrate how in various different areas, especially in the area of health, we have progress with public-private partnerships in terms of financing health services, provision, with precisely the retreat of the state. And it's a privilege to have both of them here with us this morning. And I want to remind you that this morning, the NHS, we always cite in Brazil, the NHS, we want an NHS in Brazil. NHS is no longer the same thing as it used to be. NHS has changed. The NHS on July 5th this year celebrated 75 years. And if you look today at The Guardian, day before yesterday, The Guardian, it's committed to the issue of deterioration of health services, public health services. And The Guardian shows the results precisely of a survey that was conducted in the UK, showing that 71% of the staff, nursing and medical staff under the NHS, state that they don't have the necessary time to care for patients, and 74% of them say that everything got worse after the pandemic, unlike the expectations and hopes that we had that there would be a valuation not only of these professions but also public health care provision. This survey shows, in a word, a number of difficulties, but people who follow The Guardian, we collect a number of articles from The Guardian, and today England is one of the countries with the worst, some of the worst indicators in maternal mortality. It's worse than Europe. And in the last 10 years, the British government had to compensate families for the deaths of mothers and of babies during labor of £100 million. So it's to understand that we always use the metaphor, we were influenced by the NHS and so forth, but this idea of public services has disappeared, has been disappearing. It's precisely the time that we have here today with Kate and Jasmine. It's to understand what are precisely the paths that lead to this change and have led to this change. I want to thank you all for attending, especially again thanking Professor Francisco for this initiative to convene us and convene all these institutions. As I said, I hope that we can do this again and very soon. Thank you very much. Thank you very much, Lena Lavinas. We want to thank you for the opportunity to be here with you all. And in a word, I believe that this prospect for discussion that we have in health economics, that it is beyond the narrow discussion, economic discussion per se. It's essential. The vision that health economics has an interface with the greater dynamics with the economy, and we think of financing this health system as well. This is increasingly clear. It doesn't get to discuss the financing of the SUS per se. We have to understand what is happening with the underfinancing or the definancing, understanding the process underway in the economy, and not only the Brazilian economy, but the world economy. It's an excellent opportunity, I believe, for us to be able to learn here from each other and understand these dynamics better. I would like to take advantage of the opportunity to thank the Abrasco, the Brazilian Association of Collective Health, and the researchers from the University of Campinas with the support here that they've given us, and Isabella Santos, who is the vice president of ABRES, but she's the coordinator of public policies under the Brazilian Association of Collective Health, Abrasco, and she has supported us extensively in this issue, and including in Fiocruz, where she is a researcher. Fiocruz has an important role and a major contribution for us to make this event possible. And I would like to thank especially Luciana Lima, who is the Vice Director of Research and Innovation at the Oswaldo Cruz Foundation, Marco Antonio Carneiro is the Director of Eduardo Alves Melo, who is also the Director of the Government School of Government. He is the coordinator of the SUS Observatory, or the public health system. I would also like to thank and acknowledge the support for this structure here in the event. I would like to thank Carlos Gadelli, who is the Secretary of Science and Technology in the Ministry of Health in Brazil, Erica Aragão, who is the Director of the Department of Health Economics, Inputs and Development in this Secretariat under the Ministry of Health as well. And also they were quite important for us at this moment. I would like to turn the floor over now to our guest speakers. Thank you very much, and thank you for sharing with us this morning.
So much for inviting us to be here. Obviously, huge thanks to Lena for inviting us and hosting us, but also thanks to all of you for coming, and looking forward to discussing what's happened in the UK and finding out more about what's going on in Brazil. I've called this financialization of England's health and social care, but to be fair, I don't really talk about social care. I'm happy to talk about it in the discussion, but there's so much to say about health. We can talk about that later if we want. Okay, so this is what I'm planning to cover. How the NHS is structured, recent performance, which you'll see things have got worse. The policy trajectory, are we seeing the end of neoliberalism? We can discuss and I will talk about the shifting roles of the private sector in the health service. So, as you may know, our National Health Service, the NHS, was founded in 1948. This is a leaflet from when it was set up. Does this, how do I do? Oh, well, I'm not sure what I'm doing. Anyway, you can see. It's interesting at the bottom, they say, at this leaflet, it's not a charity. You are all paying for it, mainly as taxpayers, and it will relieve your money worries in times of illness. I mean, this was an amazing thing when it started in 1948. The founding principles were that it would be comprehensive, services would help everyone, be universal, healthcare would be free at the point of access, and access would be based on need rather than ability to pay. So this was momentous. The initial budget was £437 million. So, as Lena mentioned, the NHS turned 75 only a few weeks ago. And, well, as we'll see, things have got much more expensive and much more complicated. Okay. So the health expenditure is predominantly financed by taxation, by government schemes. So that's 83%. We have 13% is out-of-pocket expenditure. And we have some voluntary health insurance and some other small charity organizations, but it's pretty much all public funding or out-of-pocket. So we don't have any sort of compulsory health insurance. So I was trying to find something to show you how the finances worked, because it's all very complicated. And I found this. This is the simple version. So this is how the finances flowed in 2018-19. So let's see if I can make this work. I don't know if I can do it. Anyway, okay. So we start with the Treasury, the government budget, and then it goes to the Department of Health and Social Care. And then some of the money comes out from here to capital spending. Some comes out to public health, vaccinations. And then the rest goes to goes to this organization, NHS England. So NHS England then spends some money on sort of national health initiatives like treatments of rare cancers. But most of it goes through to this system here, clinical commissioning groups. They've actually were changed last year to a different kind of structure, but the same principle remains. These are regional organizations that are the ones that spend the money. So they're responsible for spending money on the services. They decide what gets spent on hospitals, on general practice, on mental health, on other community providers. So this is the process by which it reaches the front line of service provision. And the service providers get some money also from local government and also from some private systems. So that's a kind of overview of how it works. Overall spending has increased. I mean, spending on health always increases. In real terms, this is since 2008. This is the Department of Health and Social Care spending. And obviously we have a big spike during COVID. We're projecting these increases here. So spending increases because we have population growth, we have life expectancy increasing, we have economic growth, we have advances in technology. All of these things mean that we always increase what we spend. But what's different in different political regimes is the rate of growth. And this is quite clearly delineated by the different political regimes. So this was research by the Institute of Fiscal Studies. So before 79, we had the spending growth rate of around 3% per capita. Then under the Thatcher governments, the Conservative governments, we had growth rates still of around 3%. But under the Labour governments of Blair and Brown, we had a big increase in health spending growth. And at the end of their term, they had one of the lowest waiting lists, and they had the health system was in pretty good shape. But then we had, this was mainly a Tory government, but a coalition government and a Conservative government, and they have, the rate of growth of spending has shrunk dramatically. This has been austerity in action. And this has had quite a big impact on how the system is working. So this is health services expenditure as a share of GDP. And this is since it began, it's kind of gone up. These are different political regimes. So this is Conservative, Labour, Conservative in the 90s under Thatcher it plateaued, went up a lot under the Labour regime, and now we see under the Conservative government it's actually come down as a share of GDP, and that's COVID. So that's I'm not really going to talk about COVID because it kind of just messes everything up. So alongside this, we've had a dramatic increase in demand, increase in numbers calling their doctor, increase in ambulance calls out, increases in the people being referred for surgery. So massively increasing demand, not much going on with pending. So that's why we're seeing some of the outcomes that we are. So these NHS trusts, these are the people, the service providers at the end of the purple snake diagram. They are spending more than their income, and they're slipping into deficit. So this was when the Tory government came in, and then they slide into quite substantial deficit. It looks like there's a surplus at the end, but that's a COVID anomaly. So many providers are predicting they're going to be spending more than their income in 2023. So more funding has been announced, but it looks like we're still on a trajectory of pressure on spending. Providers are expecting to struggle. We have rising demand, we have inflation, and we have major staffing problems, as Jasmine will tell you. And what this means, if a trust is in deficit, it means there's tremendous pressure on financing. So staffing is the core element of that, but there's other costs that are being cut to try to resolve the deficit. So compared with other countries, we're spending just below average as a share of GDP. And then this study is interesting. It compares the UK with 19 other countries. And so the UK it's here. So we're slightly below average on spending as a share of GDP, but we're quite a lot below average on spending per capita. So this is feeding through into the outcomes, as Lena mentioned. So we have, this is the UK here, compared to, this is the same study of 19 countries. We have, as the report authors said, strikingly low numbers of doctors and nurses per 1,000 population. I should mention, though, we do have one good thing. We have very low administrative costs. That's a bonus. But a lot of quite bad things coming out in this comparison. We have not been spending so much on capital investment, and building maintenance is a problem, this shows that coming through, we have fewer, this is the UK here, CT scanners and MRI in comparative countries. And where we have fewer general hospital intensive care beds than our peers in this group. So again, the UK is quite low down this on the number of beds per 100,000 population. And this was a big problem with COVID. And this is feeding through now into health outcomes. We have higher rates of mortality from avoidable causes. We have the average 30-day mortality rate for heart attacks and strokes. So survival rates are lower than average than these comparative countries. We have below average survival rates for many cancers, breast cancer, cervical, colon. This is challenging the simultaneous translation. Colon, lung, stomach, the different types of cancer. We have lower than average survival rates. We have higher than average infant mortality. This is another study which highlights our post-COVID outcomes. So the waiting list to start planned care is rising. It was very high before COVID. Now it's gone even higher. 7 million people waiting to start planned care. 41% of patients waiting to start treatment after a cancer, after a GP referral, so you're referred by your doctor. 41% waiting longer than 2 months, and waiting times at accident and emergency units are huge, really high. So it's quite a grim picture. And this is interesting. We have higher than average out-of-pocket spending on health, which started going up here in 2010 when the Conservative government took over. And now this is the average for high-income countries. It's coming down, and now we are up there. So people are finding ways around the limitations of the health service, particularly the waiting times, spending their own money. Okay, so just a bit about the policy trajectory. So it was really in the 90s with Margaret Thatcher, the Conservative government, that the marketisation of health began to take hold with this idea of an internal market. So it wasn't privatised, but we had a separation of the buyers of care and the suppliers of care, which is when we came to, as I mentioned, the clinical commissioning groups were effectively buyers, and then the providers are like the sellers. So this market was really important. And then that developed further into a tariff system and the notion of what they call payment by results. And an important element of this developed under the subsequent Labour government was that the payment could follow the patient. So you have a price put on a type of surgical activity or a medical process, and then that can go with the patient. That then meant it easier to allocate patient activity to private hospitals, because this was another important part that came in under the Labour government, was the outsourcing of some services to the private sector. It started with the easiest services, things like hip replacements, cataract surgery, these easy services. The health service funds, it's funded through taxes, but it's carried out by the private sector, so it's an outsourcing. And the element of this is patient choice. So again, this marketisation is getting more deeply embedded. And then another dimension to the increasing role of the private sector was PPPs, public-private partnerships. So these began in 1997, and they were taken up by the subsequent Labour Party substantially. So PPPs so this, it's quite complicated, but it's showing, it's a report by the National Audit Office that shows the impact of a PPP policy on the flexibility of the health budget. So PPPs was a system where the private sector would come in and build a hospital rather than funding it through tax. And then in the contractual arrangement, the health provider, or whoever the contract was with, but basically the health finance would pay for this infrastructure over a long period of possibly decades. So this was a way to get your infrastructure built quickly, but was very expensive. So this shows that cost pattern. Initially you have money coming in, but you have much more going out over a very long period. Now, PPPs were actually stopped in the UK in 2018. The Treasury, they said these were what they called a fiscal illusion, because they don't bring money, they actually cost money in the long term. But we're still paying a high price, a legacy price. So this is the payments for PPPs for the up until 2060. This is for the government as a whole. This is for health. So they were stopped here, 2018. The government said no more, but we're paying these payments up until 2050. So they've been hugely expensive, and there's very little benefit from them, and very crippling for some hospitals who have been forced to use them. But we don't have them anymore. So, yeah. But just on the trajectory, we had a new act in 2012, the Health and Social Care Act, which really pushed the idea of markets and outsourcing and competition in health providers. And I think in a way it was kind of the limit to our commercialization of health, because the problems began to really come out after that. The problems in having competition and not cooperation in health. So we now have a new act. That's another thing about our health service. We're having reform after reform. But the new act in 2022 is all about integration. It's become really clear the market system is limited. So it's all about integrating different types of health provider. Whereas before we had an emphasis on segmentation and different elements competing against each other, this is recognizing our primary and secondary health services, mental health, community health, all of that, and social care, we all need to work together in an integrated way. And in this, as part of that, if you like, the buyers of care, which were clinical commissioning groups, are now integrated care boards, and they include local authority representation, they include social care, so they include civil society. So the idea is it's much more place-based and is able to respond in an integrated way to improve health outcomes. So, and the whole tariff system is being completely revised. So I think it's fair to say we're seeing a big shift in ethos, but we're stuck with this legacy of the private sector and austerity. So there's people say the NHS is being privatized, but actually it's not happening in terms of transferring the public to the private sector, but it's being eroded in a much more subtle and pernicious way. So the spending on independent private providers hasn't increased as a share of the overall budget. And the more recent data, even with COVID, we didn't see much more of a share going to the private sector. So it's not really being privatized. But there are differences across different sectors. So routine surgery, I say hip replacements again, they are about 30% are carried out by the private sector. Mental health services are very much provided by the private sector. Mental health, residential care, the NHS capacity has absolutely plummeted, huge drop in beds. So this is a strong area for private sector. Community health also, a lot of private sector involvement. So we're seeing the private sector coming in some segments. Another dimension, I'll mention this. Part of the 2012, what I call the high water mark of commercialization, allowed the NHS to sell services to the private sector. It massively increased the share that private providers could generate from selling their services to private customers, which really potentially could be very destructive. But again, we haven't seen a big take-up of this. But what we are seeing is a shifting relationship with the private sector. So we're seeing the NHS partnering with American private health companies. So these are NHS hospitals, University College, the Christie guys, and they are now in partnership with these big American health firms. So these are the kind of ways that the private sector is getting closer to our health services. Another dimension is, this is what I'm talking about. New investors and new financial practices are coming in different ways. So GPs, general practitioners, they have actually always been in the private sector. It was part of the arrangement when the NHS was set up. But these were small individual partnerships. But now they've begun to build up chains, collections, a collection of practices. And this was happening quietly. And then in 2020, a chain was sold to an American company. So now we have American private health in the center of our health system. So it's, again, it's these subtle changes that are happening. And it was shocking when it happened, but the groundwork for it goes back like 20 years. But we didn't realize. Mental health, as I said, mental health is predominantly provided by the private sector, funded by the state. So these, and it's very concentrated, the sector. So these 4 companies here provide 65% of the market, if you like. And we have the Priory is owned by private equity. This one's a private equity registered in Luxembourg. That's a charity, and that's an American company. So I looked a lot at the accounts of the Priory Group, and they provide 10% of all of our NHS-funded mental health beds. And the company's been sold back and forth from private equity to American health companies, each time loaded with more debt, sometimes at high rates of interest, paid to another corporate company based in a tax haven. And all of this leakage is coming from our health budget. And then another example is Virgin Care, who have a lot of contracts for community health. So they won a lot of projects for providing community health. Virgin, do you know, is Virgin famous here? Virgin is owned by Richard Branson. But yeah, the guy from the airplanes, as Lena says. So when they did this, they were saying it was like a philanthropic project. So this is what Virgin Care said. Neither Virgin nor its founder has ever taken a penny from the business, instead committing to reinvest returns into the company and its frontline services. So the idea is that this is a kind of charitable thing. Okay, then in 2021, they sold it to 2020 Capital, a private equity company looking for significant returns. So, yeah. So this is, again, the ways in which the private sector is getting involved. So, COVID, I won't say much about COVID. COVID was a boost for the private sector anyway. Yeah. We gave a lot of money to private hospitals. They were supposed to be backup, but of course they didn't have any of the expertise that was needed to actually be helpful during the pandemic. And we are going to give them lots of money now to help deal with waiting lists. And yeah, anyway, conclusion, right. So the ethos of the new legislation is a significant shift away, I think it's fair to say, but we are really struggling with austerity. It's been hugely damaging. Self-pay has become normalized, and private providers are coming in to offer financial deals for people to get their operations done. And it's really contributing to a narrative that the health service is unaffordable. And there's a lot of public debate about this. And as I said, the private sector is quite entrenched in some segments and is becoming quite powerful. So with these integrated care systems into 2022 Health and Care Act, they are pushing to have a big role in shaping health because they are providing mental health, they are providing community health, so they want to be involved. So there's a lot of tension around there. So they're very embedded, even if we're not privatizing anything. The evolution of privatization is under the radar. It was a surprise that the American firm took over our GPs. We didn't know this was happening, and then bang, it's a big thing once it comes out. Political messages are mixed. On the one hand, we have this call for integration, but then we have even our Labour Party is saying we need to work with the private sector. And the NHS is highly politicized. I'll just finish with this chart that I thought was really interesting. The mentions of the NHS per 100,000 words spoken in the House of Commons, that's in our Parliament. I mean, amazing research for someone to do. So the NHS was barely mentioned for its early years. And again, this is the different political regimes. The Conservatives, Labour Conservatives. So the kind of escalation of the NHS in government discussions, highly politicized. Yeah, that's, yes, it's not simply a health service, it's a political issue. Thank you.
Obrigada.
Thank you so much, Kate. I think that we had an excellent summary of the various different formats in privatization and financialization underway. And we know that there are a number of elements here that are similar to things that we've witnessed in Brazil. I think it's one of the important points for us to discuss is this diversity of dynamics. There's not just one single direction. There are various different actors, different dynamics, and different accumulation processes. So I believe that we've had a beautiful overview now, and I'll turn the floor over to Jasmine for her to continue with the discussion.
I would also like to thank Lena very much and all the colleagues involved in inviting Kate and I here, and thank you all for turning up. It's a real privilege to be here and to share these insights with you. So I'm going to kind of carry on from where Kate left off and expand a bit on some of the health inequalities and also the staffing issues. And I thought I'd just sort of flag up a few points here from Kate's paper that, in a way, the conclusions to what I'm going to say, but I thought I'd just flag them up now, just partly so I don't forget. And I think, you know, one of the things that really struck me when Kate was talking was this idea that the NHS was founded on and emphasise the importance of access based on need rather than ability to pay. And I think as I progress with my presentation, you'll see that that has really been challenged. Also, I think one thing we need to bear in mind is that, of course, you know, Kate's data showed very clearly the impact of austerity policies in the NHS. But of course, these are affecting society at large, and we're seeing declines in housing expenditure, education, and rising poverty levels. And of course, we need to bear in mind what that means for the social determinants of health. And as Kate was saying, although there's this shift towards a more integrated health and care system, again, you know, when the backdrop of that is more and greater inequality, we have to really think how that's going to play out. And also, I think we need to bear in mind, you know, the rising out-of-pocket expenditure. And I've actually done some work on out-of-pocket expenditure in Latin America, and the evidence shows really clearly that there are very noticeable gendered impacts of that. And, you know, of course, that has got serious implications for rising gendered and racialized forms of poverty and inequality. And again, you know, when you know, in terms of the social determinants of health, when community care, so health promotion, health prevention, when all of that is being privatized, and again, sort of vaccinations for children are being provided through virgin care, again, we have to really question what this means in the longer term. So that's the kind of backdrop against what I'm going to say, and of course Kate's paper sets out very clearly the funding elements. So I'm going to start by talking a little bit about the staffing crisis, which Kate referred to, and clearly linked to austerity policies. And I'm going to focus on nursing. I mean, the staffing crisis impacts the entire sector, but I'm going to just focus on nursing because I think it highlights many of the issues around that. And then in terms of the kind of deterioration in care and what this means for health inequalities, I'm going to talk about maternity care. And then I'm going to talk very briefly about dental care, because in a similar way to GPs, these have been, dental care is private, but nevertheless, children and pregnant women have entitlement to free NHS dental care, and also NHS dentists are meant to cap the cost of dental treatment. But what we'll see is that there's a real deterioration in availability of NHS dentists. And of course, you know, that's not just about having nice gleaming white teeth, it's about oral health in general and what that means. And then just some final reflections. So at present, there are over 110,000 full-time vacancies across the NHS, so a really massive number of vacancies. And although some of you may have been aware that in June 2023, this year, the government, to great fanfare, announced this new workforce plan with headlines around, great numbers of new training and of doctors and nurses, and an attempt to kind of stem the flow of international recruitment into the sector. In reality, there's a lack of detail around how this will happen, and there's been a lot of criticism because one of the ways in which the government intend to address this increase of training is to actually reduce the number of years of training and to introduce practical apprenticeships rather than, for example, I think it's 7 years for medical training, and I can't remember how many years for nursing training, but the idea in the proposals is to reduce the number of years of training. And so, of course, this has been really widely criticised as a de-skilling of the profession, and also a lot of political controversy around how the plan is going to be paid for, and part of the proposals for funding the plan includes increasing the amount that overseas visitors have to pay for healthcare services. So again, very sort of clear political message and a very problematic message. And in reality, there's a lack of detail of how this expansion of the workforce is really going to happen. So I think there's a lot of skepticism about how this is going to play out in practice. And it's also been criticised because it fails to address the issue of staff retention, which I'll talk about in a minute and we'll see as a really significant problem. It doesn't address the pay issue, which I also talk about, and there's been a huge political issue this last year with lots of strikes across NHS workers. And it doesn't address the need for investment in the system. And again, Kate's slides showed very clearly the declining hospital infrastructure, both in terms of equipment, but also buildings themselves. And as Lena mentioned, there was this survey published in The Guardian last week, or this weekend, where 71% of NHS staff report that they don't have enough time to spend with patients. And clearly this is very closely linked with this understaffing of the system. So here on the right, we have an image taken from the NHS strikes in January this year, or December, January. But the NHS currently employs around 320,000 full-time equivalent nurses and health visitors. And also quite a lot of nursing staff who, as I say here, a majority women, do work part-time. And again, this raises questions around the kind of quality of work. But nurses account for around a quarter of all NHS staff and around 40% of those staff vacancies. So that 110,000 vacancies, 40% of them are for nursing staff. And in 2020 to 2021, the nurses' pay bill accounted for nearly 1/3 of the overall staff bill. But one of the reasons that nurses are striking, or all NHS workers are striking, is that in real terms, nurses' pay fell by 5% over the last 10 years. And so, as I've flagged, one of the real challenges in the system is the retention of nursing staff. This is a report from the National Medical Council, and it highlights that the number of nurses leaving increased by nearly 3,000 in 2021 to 2022. So, and this was despite it previously declining. And obviously some of this is post-COVID, but there's a feeling that this is, that this is an upward trajectory. It's not declining. And in line with the kind of survey from The Guardian that I just cited, this National Medical Council survey says that the main reason for nurses and midwives leaving the profession is that they feel undervalued, they're experiencing burnout, and that low pay has not kept up with inflation. Also, the nursing workforce tends to be older women, and that they're not being replaced by younger women. So again, there are concerns about, how that, as that older group retire, how they're going to be replaced. And we've seen that, that people are not training, not taking up these great offers to become nurses. And so there's a concern about the long-term continuity of the workforce. Also, regional variations in these staff vacancies and gaps in the workforce amongst nurses, and they're particularly high in London and the South East. And of course, this is linked with the fact that, the London and the South East are the most expensive parts of England and indeed the UK. And so nurses cannot afford to live in London and the South East. So we're seeing a massive exit of nurses from the capital region. And also the gaps in staffing vary across the types of services, and they're most significant in acute care and mental health care. And again, these are obviously really significant areas that remain understaffed. And one of the big issues, and this again has been quite prominent in the Guardian stories in this last year, is the growing poverty that we're seeing amongst nurses and other low-paid NHS workers, including junior doctors who are also striking. But there's also a very clear racial element to this and a gender element. 28% of nursing staff across England are black and minority ethnic, and this is the highest of any NHS staffing group. And there's clear evidence, or there is evidence, of both a gender and ethnicity pay gap amongst NHS nurses and more widely in the NHS, but there's a lack of data, partly because this data hasn't previously been collected, but there's now a kind of push by, or there has been, but this has now finally been taken on board, a sort of push to collect this data to really show how these things are playing out. But as we've seen, and as I'll kind of talk a little bit more, there's still a or not even a reluctance, a refusal on the part of the government to acknowledge structural racism within the NHS and the health sector. And this again is a kind of major challenge to how we address these inequalities. And women are more likely to work part-time and face occupational segregation and a lack of training opportunities. And here I mean women within the NHS. And of course this reflects wider trends, but this National Medical Council report emphasised that these were issues for women in the NHS. And what is perhaps most shocking is that these nurses, what we're seeing amongst nurses, is an increased number of nurses resorting to using food banks. So unable to buy food and taking out private loans, so from banks, but also from, what we call loan sharks, to pay their bills. So a real sort of impact on their ability to survive. And I think, in January 2023, there was an announcement that over half our NHS trusts in England are either starting or considering starting a food bank within the hospital just for NHS staff. So really shocking statistics. And on the right, these are all Guardian headlines, just to kind of show that there has been a lot of public attention on these issues. So perhaps unsurprisingly, nursing staff and NHS more widely have had enough this year, and you're probably aware that there's been quite a lot of industrial action, both of NHS staff, but more broadly, including academics, over the last year. But what was particularly significant is in December and April and May of this year, nurses, for the first time ever, announced industrial action, and that both times they took 2 days of industrial action. And this, of course, has been really significant, but also strikes have also taken place by junior doctors, ambulance staff, and even consultants. So, you know, kind of senior doctors in the system who are claiming, you know, with evidence that they are significantly underpaid and that their pay rates are not keeping pace with inflation. And the nurses, for example, were demanding a pay rise of 5% above inflation, but last year the pay offer was only £1,400, so significantly under. And I think the government is claiming that, you know, they want an equivalent of 35% pay rise is what they're asking for in real terms, and they're refusing to give this. And as far as I can work out, that, you know, this is an ongoing debate. It's not been resolved. And again, what is particularly striking is that, of course, hospitals or NHS trusts are recruiting agency staff, so kind of, you know, hourly paid staff to replace the nurses that are on strike, and that overall the cost of the strikes to the NHS is £500,000 per day per NHS trust, so not even across the whole system, that is per trust. So there's a real massive cost, but there's still a political resistance to, you know, addressing the demands of the healthcare workers. Okay, so moving on to talk a little bit more about maternity care, where we also start to see how these staff shortages play out in real terms in terms of how people access and use the service and the quality of care that they receive. So just to kind of set out there what people's entitlements are to maternity care in the NHS. And I should say, I don't have the percentage, but the majority of people still do give birth in the NHS. Of course, there are private clinics, but these tend to be more for very high income people. I think there's still a kind of a culture of, even amongst, you know, upper middle class women, that you give birth in the NHS. But in 2016, there was a report commissioned for the NHS called the Better Birth Report, and it advocated the importance of wraparound care for women, so that, you know, rather than this kind of one-size-fits-all, that every woman should have a kind of personalised service available to them that gave them what they required, the option to give birth in a hospital, to give birth at home, or to give birth in a special birthing centre where maybe you could have a water pool and family members could be present. So basically to give women the kind of birth experience that they might choose to have. Yeah, and this applied even to birthing people who did not identify as women, so a very kind of well thought out, well articulated plan in line with the kind of ethos of the NHS that Kate set out. And in 2019, the NHS long-term plan reiterated the commitments that were made in this report, and they advocated the importance of a life cycle approach that started, you know, kind of reiterating this from the cradle to the grave. And it also made a commitment to ensure continuity of care for most women, so that they would only see, you know, one, possibly two midwives throughout their pregnancy, and there wouldn't be a kind of, you know, rapid changeover of staff. They'd be able to develop this relationship with their midwife throughout their pregnancy and into giving birth. And again, this was reiterated in the integrated care plan. It was intended to address the multiple disadvantages faced by many women and ensure joined up care. So again, addressing the kind of wider social determinants of health and the fact that, you know, many women might have, for example, mental health issues or poor housing. And this integrated care plan was meant to, you know, kind of link different government or agencies and ensure that people, you know, that a midwife would know everything relevant there was to know, and that would be reflected in this kind of wraparound care that was going to be on offer. But as Lena noted in her introduction, there's been a real plethora of awful statistics that we've been seeing of evidence coming out and being made, put in the public arena about mothers and babies being put at risk due to unsafe maternity care. And I should say these are all from the last 6 to 12 months, these reports. They're not old. There's been inquiry as dozens of babies and mothers died or injured in childbirth. Maternal mortality has risen by nearly 20%. Alarm at the decline of women's maternity experiences. So the headlines suggesting that actually, despite all this legislation and so-called commitment on the part of the government and the NHS, this is not happening in practice. And we've seen, for example, a 2015 review into the quality of NHS maternity care had found that women report being denied pain relief when they requested it, feeling unsupported during labour, and that 26% of women did not feel involved in decisions about their care. This is, despite this wraparound care being offered to women. In some trusts, up to 20% of women were left alone during labour and birth, and that wasn't them asking to be so, it was just being abandoned by staff, because as we've seen, their staff are just not available to provide the kind of care that the NHS claims they will be given. And 85% of women reported being attended by a midwife during labour that they'd never previously met. So a clear failure to deliver on the kind of commitments that were made in the plans. And I just also thought as well it's worth drawing attention to maternity charging that happens for migrant women. And again, really challenging this idea that that the NHS offers services based on need rather than the ability to pay. And free care, maternity care, is only offered to those who are ordinarily resident, and there's an NHS charging programme for others. And there's an organisation called Maternity Action, who is an NGO campaigning around this and drawing attention to the experiences of migrant women in particular. And they argue that this charging programme is very much clear evidence of the hostile environment to migrants in the UK, particularly to undocumented migrants. Because one of the problems is that NHS trusts rely on women to determine for themselves whether or not they have to pay. They are not told, oh, okay, you don't have entitlement, you're not someone who's classified as ordinarily resident. So women are left not clear as to whether or not they have to pay for these services. And of course that causes massive anxiety. I'll come back to that. And this is a quote from some qualitative research Maternity Action did, where they say, charging has a deterrent effect on women's access to maternity care, which poses risks to their pregnancy and the health of their babies. Anxiety about charging has an adverse effect on maternal mental health, with consequent effects on women's pregnancies and pregnancy outcomes. Although all maternity care is designated as immediately necessary, this does not compensate for the anxiety women feel knowing that they are unable to repay very high charges. So really concerning. And one of the particularly problematic aspects of this is that women are not actually charged up front. It's not like, you have to produce your check, otherwise you're not allowed to enter the hospital. You go in not knowing whether or not you're going to be charged, and then when people don't pay, and it's £7,500, which I should have converted it, but it's probably around $10,000, I think. If people don't pay, the debts are passed to debt collection agencies, so they are aggressively pursued for the money. So again, raising really significant issues. And another important part of this story is that although the NHS makes commitments to providing language support for non-English speakers when they come for services, and again, this is all meant to be provided free of charge, very often that doesn't happen, and particularly it doesn't happen for undocumented migrants. And so although language support is supposed to be available, it's often lacking in practice. Or again, I think there used to be more common that you'd have an in-person translator, so someone would come into the room and you'd have a person there to help you communicate. But now often, because of cost cutting, translation services are a telephone service. So again, really, challenging as to how that can happen. And that's not just around maternity care, but in general. So it's actually very challenging to get language support. And just a small aside, I've done some work with Latin American migrants in the UK, and one of the problems is that also Latin Americans are not classified in the national surveys, national census, as a minority group. So quite often Spanish and Portuguese is not available as a language for translation. So again, it's a real issue for the Latin American community in the UK. And if you want to ask, we can come back to that in the conversation. So, as the headline suggested, and as Lena intimated, maternal mortality has increased in the UK. So it's increased by 3% over the last decade, and that excludes COVID-19 related maternal deaths. So it's currently at 7 per 100,000 live births. There's significant socioeconomic and racial disparities in maternity care, and Black and minority ethnic and Asian women are particularly significantly featured in this increase in maternal mortality. So we see here that Black women are nearly 4 times more likely to die than white women, and Asian women were 1.8, so nearly twice as likely to die than white women. So clear racial disparities in this provision or lack of care. And 1 in 9 women who died during or up to a year after pregnancy in the UK were at severe and multiple disadvantage. So again, raising real kind of questions about this ability of services to provide any form of integrated care, and the failure to kind of join up with the wider issues impacting on the social determinants of health. And we see that women living in the most deprived areas continue to have the highest maternal mortality rates. And the Office for National Statistics notes a clear overlap between high socioeconomic deprivation and ethnic minority background. So there's a serious concern about racial inequalities in health outcomes. And although there has been some attempt to make this more of a political priority, and there's a nursing and midwife code, for example, that sets out professional standards and clearly states that the interests of people giving birth must always be put first. But what we see is that Black women are frequently othered. I don't know if that expression translates into Portuguese, but made to feel that they are different. And healthcare providers failing to offer the kind of individualised care, this wraparound care that the NHS is meant to provide. The review by the NMCC also found that the vast majority of women who die across all ethnic groups have multiple and complex problems, and that the maternity care system was not set up for this. So, for example, women may have to attend different clinics at different hospitals, which are not effectively communicating with each other about the complexities of patients' case. So a lack of kind of communication within the system that's just not working effectively. And also, people report a lot of microaggressions on the part of hospital staff. So, for example, there's this belief that Black women have a higher pain threshold, and also the ethnicity of non-white women is often not recorded properly, and this can have serious implications for the kind of health conditions that those ethnic groups may experience. But also, I don't know if any of you have seen in the UK recently, there's some work that's been appearing in The Guardian again about the failure to identify jaundice in black and minority ethnic babies, and there's been some acknowledgement in research terms, not within the government, of course, that the measures used to identify jaundice were, of course, designed for white babies, and that they don't apply in the same way to black and minority ethnic babies. I can't explain the science now, but that this, the kind of measures that are used are just not effective. So again, we're seeing higher rates of jaundice in black and minority ethnic babies that actually could be easily addressed if these procedures were reimagined and rethought. And so again, evidence that women endure both implicit and explicit racism within the NHS. So what is being done then to address these inequalities? Well, as I kind of highlighted, I think one of the big issues is this lack of staff. And based on what I was saying at the beginning, it's questionable as to whether the proposals, the plans to increase staffing are really going to effectively address these issues. And there have been several recent expert reviews of maternity care, and they've found that, for example, there's a lack of focused strategies to address inequalities, there's a lack of data on black and minority ethnic experiences, and communities themselves are underrepresented within the research. And what's particularly concerning is there is a government resistance to address some of the expert recommendations. And for example, this maternity disparities task force that was established in 2022 has actually not met for 9 months. So it doesn't really suggest a commitment to addressing these issues. And also, race is actually excluded from the terms of reference, and instead the focus is being pushed to look at things like preventable risks, so smoking and drugs. And in 2021, an NHS Race and Health Observatory was set up, but actually there's no kind of government commitment or leadership on this. So again, it raises questions as to how effective any of their findings are going to be. So just a couple of brief insights or reflections on dental care, because again, I think this highlights that it's not just in maternity care that these things are happening, and we're seeing kind of parallels of increasing racial and gendered inequalities across dental care as well. So within the NHS, dentists are paid by the dental unit of activity, so they're paid by the type of procedure. And as I said at the beginning, all children and pregnant women do have entitlement to free NHS dental care, and there's also a kind of cap on the cost of services for others using NHS dentists. But what this payment system means is that there's no financial incentive for dentists to carry out preventative care. And there's also been a concern about the mass exodus of dentists from the NHS, and this is seen as, it's going to significantly increase in the next 5 years. And this is again in response to concerns around overwork and going back to sort of feeling burnout, etc. That the chart at the beginning, the report, also included dentists as well as other NHS practitioners. And so what we're finding, and this graph on the left indicates dental deserts, so places where there is just no dentist available, or there's a lack of training, and a report of 3-year waiting lists for NHS dentists in these areas, and it's particularly acute in North Lincolnshire, which is in the east of England. And this is in part because there are no training facilities for dentists there. And the research finds that people from minority and ethnic backgrounds and lower socioeconomic backgrounds are twice as likely to avoid dental treatment because of the cost of care compared to the white population. And up to 90% of England's dental practices don't accept new NHS patients, including children and pregnant people who are entitled to free quality care. So although there are dental practitioners, they're in the private sector, and despite supposed to be supposed to take on NHS patients, they often refuse to do so. And what this means is, and you see the headline, is that, you know, people are resorting to DIY treatments. And this is, you know, we're talking about 21st century Britain. We're meant to be this high-income country, yet there's growing reports of people using pliers to pull their own teeth out. We also see a decline in access for NHS treatment for care home residents, so older people as well are particularly negatively impacted by this. And we're seeing growing levels of tooth decay in children. 4 in every 5 respondents in this 2023 report found growing levels of tooth decay among school children, and again, links with malnutrition and lack of access to affordable dental care. So going back to this kind of failure of successive governments to address the social determinants of health. And the government response in the staffing plan is to allow hygienists, etc. And Rishi Sunak, the Prime Minister, in his announcement of this was very vague about who these people were going to be. He kind of clearly didn't know what he was talking about. But this idea that, you know, these are not specialised skills that are required, and basically any old person can be a dentist and perform dental care. And that also there'll be increased use of those who are trained overseas. So not, you know, clearly a lack of government commitment to addressing this lack of dental care. So I think what we see is that the NHS is at breaking point, and, you know, this really raises very significant questions around, you know, the ability of the NHS to guarantee the right to health for the English and the wider UK population. We see poor working conditions, and of course these have a health impact on NHS staff themselves. It's not just healthcare users, it's the healthcare staff who are having their, you know, having detrimental impacts on their health of these poor working conditions. We see clear gender and racial inequalities amongst health workers, poor quality in care and challenges of staff retention, and of course gender and racial inequalities reinforced through poor healthcare services. When we take into account the treatment of migrant users, you know, it clearly raises, and even not just migrant users, but, you know, the issue of the dental care, I think, highlights this question about, you know, how effective are these ideas around universal access? Are they really happening? We're seeing as well these increases in out-of-pocket expenditure. So yes, you may get access, but it's not free at the point of delivery anymore. People are paying, and they're paying in different ways. And so what does this mean for the right to health? And clearly, you know, people are experiencing very poor quality health care. So I think it really, you know, I think what we're seeing is some very clear manifestations that are a consequence of the kind of financial decisions and political decisions that Kate outlined in her part. So I'll finish there, and thank you very much.
Obrigada, Jasmine.
Thank you, Jasmine. I think we had an excellent presentation on your part, covering sectors that we normally don't analyze or approach when we consider the public national health system. We think of primary and secondary care in hospitals and everything, but for example, the issue of mental health, it's extremely relevant to the extent that we know that generally these are treatments, long-term treatments, chronic treatments, high-cost treatments with high levels of use of medication, therapies, which can be increasingly sophisticated. Therefore, to the extent that this is no longer guaranteed, you can no longer access these services through the public sector. We can see that things change. The data that have been brought here, Jasmine, concerning the issue of the existence of racism, how black and migrant women have, in fact, the services that are offered to them, the quality is lower at costs in terms of life and loss of well-being, growing problems. And there's also here in Brazil, we know the several different feminist studies that have shown this year, that treatment for black women during childbirth is not the same when they go to for orientation in terms of reproductive rights. The issue is the same. So I believe that we've had a situation here, worrisome situation that's been shared here, showing the deterioration, to what extent the deterioration of this project for universal care, universal access to health and well-being, and as Jasmine said at the beginning of her talk as well, and Kate as well, the idea of a universal health system is that people will have access based on their needs. And the needs, obviously, they grow and increase since we have population growth, and when there are new diseases appearing and new diseases that are emerging, and none of this has been met. So I believe the situation, I would say, is dramatic, and we now have in England, and I believe that we need to stop to think of things which have a certain similarity with what we experience here in Brazil. So I would like to raise two questions. I don't know if they're questions or observations for both of our colleagues before I turn the floor over to the microphone to the audience here attending. When Kate began her work, when she gave her presentation, she said that starting in 2022, there's a new reform project where there is this concern on the conservative government, the majority conservative government, to move away from neoliberal policies. That's what she said. They reached a conclusion that, in fact, it was necessary to integrate numerous different services. So integration, it's a problem here for the SUS in Brazil. It should be guaranteed. But what have we seen in practice? We can see that the practices that we have here in Brazil in terms of the labor market, the reduction in training time for the health professions, in other words, a way of saving money. We know that the system, the training system, the higher education in Brazil is all privatized. In the UK, nobody can go to the university or do graduate studies without paying at least 9,000 pounds. When you go to graduate studies, it's even more than 9,000 pounds. So they're reducing the training time, and even so, people have to pay for their training to top it off. This logic, this neoliberal logic is implicit, and the neoliberal logic is implicit as well, when we can see that, for example, the treatment, for example, for childbirth is 7,500 pounds, and the mean wages for people who work as a nurse, for example, in the health field is 1,400 pounds. So people who work in the health system itself and anywhere else, they're increasingly, they have lower and lower salaries, and they need to go into debt in order to meet these expenses. So the financialization, it hits people from both sides. On the one side, because we have some sectors, as was shown by Kate, on the issue of mental health, for example, where you have the private equity funds which organize, structure the provision in this sector, and they are responsible for this provision in mental health. And certainly I believe that the costs are increasing there as well. This is a mechanism for financialization, where at the same time people who work in those services themselves are poorly paid, and they're financializing on the other side because of their indebtedness. So when you talk about, okay, the government decided to review its dynamics in the direction that it was taking in the services, and now they want to move away from the neoliberal logic. The neoliberal logic continues, it persists, even so, and very much determinant, because it comes from all different sides and hits people from all different sides. So when people say that 500,000 pounds per day per hospital are spent at times when, for the first time since 1948, the nurses and the physicians decided to go on strike since 1948. It's never happened before. They spend 500,000 pounds. I would like to know where this money is going when you're hiring people and outsourcing, hiring, contracting out. Certainly it goes to private equity funds. They're the ones who are behind the scenes in these companies. who bring in a lot of times immigrants from other countries to staff. They come to work in the health system. They spend a lot of time having to pay for reimburse the cost of their travels to these private companies that imported them. And certainly we have digital platforms which hire these people, but which are also the ones who have behind them investors, private investors, institutional investors, because that's the issue. We know that today, all around the world, these digital platforms in education and health, they have behind them what? Private investors, the ones who even invest money in there because they want this money to be loaned for people to be able to later pay back with interest, high interest rates. That's the logic of financial, with interest paying financialization and capital. I would like to ask and hear from the colleagues if it's possible to think this government, this conservative government, truly is moving away from the neoliberal logic or not. In fact, the challenge to the logic of universality is patent today. And today, as you know, the British government in the UK has just adopted an anti-migration law, which is the most severe law of all Europe, something that's draconian even. It's very difficult for people to even, they're going to have to pay for their own stay, and it's unprecedented. And you have a waiting line. So that's my first question. Can we talk about a government which has launched a new reform focused on rethinking integration of services when we see that in practice it appears to be questioned? So another issue is this idea of the waiting line. 7,400,000 people. When I was there in London last year, there were 6 million people. In just 1 year, it's increased by a million and a half people. And the waiting line for the NHS, this leads people to the private sector. It pushes people, and people wanted to have a hip prosthesis, a hip replacement. It costs £15,000. They go to the private sector, and that's what they do if they have to go have hip replacement surgery. I'd like to ask them if there's some mechanism for deducing health expenses from the system and the tax system in the UK, because here in Brazil we know that this is something which incentivizes precisely not only the expansion but the consolidation, the diversification, the supply of services by the private sector. So, likewise, what we can see, for example, is the exodus, not only of the staff, but the Guardian showed another article showing that the physicians no longer want to stay in the UK. The British physicians are deserting UK, and they want to go to Europe, they want to go to the United States, they want to go to Australia. People want to make money. It shows that the logic, neoliberal logic, the idea that I want to get return on what I do, which is a monetary return and recognition that this is important. Obviously, if this is happening and increasing, it's going to be necessary to bring immigrants to be able to care for the issue of teeth, dental care. People are not necessarily dentists, but they're just there to show how they do oral hygiene. It doesn't solve the problem of a person that needs a dentist, obviously. But how can we have a mechanism? Can we say that it is not a kind of privatization, in a short-term privatization of the NHS? But is this what we're seeing that's going to happen? Because there's an exodus from all different sides. Who's going to guarantee perhaps later the replacement and these services and the supply of professionals? These are the main chains, as we saw already in mental health. It's happening in the UK. So the possibility of having chains, organized chains, bringing in services and offering services is a huge possibility. I know that in the UK, people don't have private health plans yet in general, but in France, there's a system which I consider one of the best, better at the front line in terms of services supply. Before people, it used to be the citizens in general, the state charges 75%, covers 75% of all the expenses, and people picked up an association which would cover the difference, but it's an association, a non-profit association, which are the mutual care services in the various different areas of activity and work. So we know now that these mutual care with nonprofits they're competing The competition comes from the health insurance companies. So today, it's a multinational company, an international company, has been competing and offering health insurance. So people are beginning to move for their health insurance and everything. So I think that we have, without a doubt, a tendency towards privatization and financialization, although it is still not a dominant tendency, but it comes under the radar, destroying, dynamiting, and disorganizing public provision through all these integrated dimensions that we have of devaluation of the supply of services and the poor quality of the services. Poor quality of the services is something people can't choose, want to go here or there, X, Y, or Z, and the government spends millions later compensating people for the poor services they've received. In other words, all of this is a kind of logic, a financialization logic, where what we have is some savings here, but you pay the double to compensate. What is the cost of paying for a life because the delivery was poorly performed? Today we have, so my questions are in this direction, because if you have today 110,000 vacancies, as Jasmine showed in NHS, and the physicians are leaving and fleeing, and people don't want to work in the NHS, 7.5 million people in the waiting list in the NHS. I don't see any other solution for this system to be reorganized if it's not through the private and the expansion of financialization, but I may be mistaken, and I'd like to hear from Jasmine and Kate on those questions.
Oh, Lena, so many things. I'm not sure where to start. Maybe we should have a discussion.
Yeah, ok. Então nós vamos abrir para outras pessoas. Quem quiser.
So we'll open up to the audience. But
Well, thank you very much for
muito obrigado.
your presentation. Really amazing, and I got very impressed, and it is sort of up to date on what's happening in NHS. Well, a lot of questions come from your presentation. I have three questions. One is the same way, same direction that Elena just presented. Are you already observing a growth in private medical schemes? And how much is it observed? Medical schemes. I'm not speaking about the privatization of NHS trust or the providers, the final provider. I mean the medical schemes, private health plans like South Africa or the medical schemes, intermediate operators of health plans. The second one is about the physicians. How you present about the nurse, and particularly the consultants. What's happening with the migration, what the transfer, and how do the NHS public servants compare as overall public services in England? And they have best paid, worst paid, and this. And finally, is the same happening in Scotland?
Ok. A colega lá atrás, pode passar para ela, por gentileza? Obrigada. Você podia dizer seu nome, por favor?
Anabelle Macedo, PhD candidate at ESC, Public Health Institute here at UFRJ, and thank you for the presentation. The question would be first, regarding the Topol review, the digital transformation of NHS, that is a focus on my research. I would like to hear from the professors, what is the feeling of NHS professors, of NHS professionals, if they are really being able to address the preparation of the workforce to deliver the digital transformation, that is what was promised in the Topol review, first question. And the second question about the use of health data that is being collected by Health Data Research UK, for example, recently with a maternity toolkit that is being available now for researchers, and how is it for real in the concrete offering of services? Because I'm just researching and knowing this on official documents, and that's an opportunity to hear what's the real happening. Thank you.
Pois não, mais uma questão, por favor. Obrigada. Você pode se apresentar, por gentileza?
Bom dia,
Good morning. My name is Alexandre. I am also from the Institute of Collective Health from the Federal University. I'm a PhD student in collective health, public health. And my question, great, given so many challenges which were discussed here in the system since 1948, my question is, isn't it, aren't we closing our eyes to such local issues, such important issues, for example, as maternal mortality, evasion of teams, exodus of teams, rather, lack of preparedness, and training for new professionals in the air? Shouldn't we be talking about the local issues, specific issues, and covering the general issue, but failing to treat the local demands and requirements, the local emergencies, team training, for example, because why not cover this, treat this problem to take one step at a time and not to attempt to solve all the steps at the same time in one fell swoop? Because if the system is so well structured, can it continue to be well structured, well managed, without failing to look at the specific issues to solve specific problems, and not just the overall picture or the overall problem in the more abstract sense? That's my question. My doubt at the same time, my own question of my, as a researcher in primary care. Good morning. Roberto Carlos from the Laboratory for Economic Evaluation of Health Technologies at the Federal University in the state of Rio de Janeiro. Sister organization here, sister institution. With the arrival of private companies in the NHS, I'd like to know whether this impacted the NICE with NICS in the incorporation of health technologies into the system, into the NHS, considering that the new technologies, they involve investments, a higher cost to the system, and considering that private enterprise has greater concern with regard to these costs. I would like to know, therefore, if you perceive some impact or some influence in this process in the decision making by the NICE or NICE. Okay, several different questions. And first, I'll turn the floor over to you. Would like to begin?
Oh, thank you. Thank you all so much. Rich questions, and I don't think I can answer all of them. I will offer a kind of reflection based on a few things that I picked up. Okay. I'll jump in the middle about private insurance, private medical schemes. So we haven't seen a surge in those yet, but I think maybe we will. But these are related. People will can only take these on if they have money, and we've had austerity, which has been affecting a lot of people. So we haven't seen that much in terms of private medical schemes. But increasingly, as I said, private healthcare is becoming normalized. And these companies are very excited about this. And they are offering all kinds of ways to make it easy for people to pay. So they're offering financial insurance type packages in easy, cheap ways. So I think we will see that. But at the moment, it's not very prevalent. What else? The No, people don't pay. Oh.
The private schemes are going on outside the National Health Service.
There are different things.
Yeah.
There is the NHS is paying the private sector in some areas, like with mental health, like with elective planned surgery. And then we have people paying directly to the private sector for their treatment, usually for more simple treatments.
Okay.
So we don't have co-payment. We don't have where you pay a bit and the state pays a bit.
Out of pocket schemes.
Out of pocket, you pay for the whole thing, and you do it separately from going through your doctor. Yeah.
Thank you.
That's different to some other places. So in Brazil, you have the co-payment.
No.
No. Okay, but in France you do. In France you do. Yeah. No, we don't have that. It's all very much. You don't pay for NHS. The NHS pays some private sectors, or you go.
It's clear.
Completely separately. Yeah.
Thank you.
Okay. The shift, is there a shift away from the neoliberal trajectory? This is what I was trying to bring out. There's a lot written about how things are different now. We have integrated care, lovely brochures, all looks great. And it is taking the edge off maybe the worst kinds of the effects of competition. We had some crazy things happening when competition was at its peak. So one NHS hospital was going to lose the contract to provide orthopedic services, which meant that the whole hospital system was at risk of collapse as a result. So it was extreme what was happening. And we are coming back from that a bit. But we have this legacy of extreme austerity. We have a legacy of a market framework. We have a legacy of pricing in the way the health system's run. The austerity is massive. The austerity has weakened everything. Our staff there's a massive exodus of staff to Australia and New Zealand. And, you don't blame them. Everybody knows people who work for the NHS, and they are on their knees. It's not a good place to be. Crazy levels of responsibility for very junior staff. It's quite scary. So, yeah, absolutely go and have a better life in Australia. I have every sympathy. So what we do is we bring in a lot of nurses, nursing staff from the Philippines. That's our way forward. It's not a way to run a health system by any stretch of the imagination. So what else can I say? Dentistry is where we're heading. The dentistry was ahead of the game with the private sector being involved. And if we don't, we need money. It needs massive amounts of funding and political commitment. I mean, that seems to just be fundamental. And the government still is reluctant to that. With our Conservative government, we don't want to increase taxation. And so we try and scrimp and move money around as much as possible. But without that fundamental commitment to funding the service, I can't see any way that it's going to really come back. the question about the local issues and the bigger picture, but I think the bigger picture, as we're seeing, is fundamental. It's a lack of resources, which goes back a long way. This has been years in the making. We need to look at the big picture. And we've had so many reforms to tweak the system, and we're still seeing terrible outcomes. I don't know anything about the data stuff on NHS, I have to confess, I'm sorry. And I also don't know about Scotland. The bits that I do know are that Scotland seem to be doing things better. They have a stronger commitment to public service, but I can't comment in detail on Scotland. And so just on the gaps in staffing, we have these big number of vacancies, so the way around it is to employ agency staff who just come for the day. And these nursing agencies are also owned by private equity investors. So private equity is brilliant in the way that it wheedles out the little segments that will be profitable. But also then it means we have a very strong set of wealthy vested interests that are very happy with the way that the system's going. I can't.
I mean, I don't have much to add to that either, other than, yeah, of course, I was just checking, so the doctors, senior consultants as well as the junior doctors, are threatening more strikes next month unless the government negotiates with them. The government is offering them a 6% pay offer, but doctors are arguing, rightly I'm sure, that since 2008 they've experienced a real 35% pay cut. And again, part of their discontent is this concern that the NHS is going to become a two-tier system, because as well as moving to work overseas, a lot of doctors are starting to move into private practice. And so again, this is because, yeah, so there's real concerns about that, and that's why they are threatening to strike, likely to strike again, because the government won't negotiate with them. And also, it's not only nursing staff that are provided by agencies. Quite often we get, when there's strikes, or, at the GP surgery, your doctor's away, and often you get a locum who's come through an agency. So I think there's a lot of these kind of practices happening already, as Kate has said. Yeah, and just to pick up on the question about the kind of the local issues, again, I think, when we think of it from a social determinants perspective, again, one of the huge issues is that at local level, local authorities are responsible for things like health promotion and care of older people. And again, we're seeing massive cuts in local authority budgets. So they're kind of exacerbating all these issues. And again, cuts in school budgets, in education budgets, and all of these, we see these interconnections that are just getting worse and worse at local level. So I think, yeah, it's definitely, there's the top-down view and the bottom-up view, and none of it is positive. And similarly, I don't know anything about the data. I can't answer that, but important questions nevertheless. So, yeah.
Eu vou fazer uma nova rodada, mas eu antes queria apontar.
I'm going to make another round, but I'd like to point out to something Kate said. You cannot increase the private sector because there's such huge austerity, precarization of service, professors, a cut in budget, as Jasmine mentioned, in schools, education. Everything has been privatized. Everything has been turned worse. Why the private health service does not grow? Because austerity that reduces the wage of workers asks it to increase. this actually is the trade-off, what we could call of austerity itself. Because austerity is so huge that it starts preventing people from being able to pay for health care services. So you cannot expand sufficiently the private sphere of service of healthcare. And what happens on the other is there's the other side that they've shown deterioration of all indicators. Why? Because we have no public and there's no private. People have no resources to go to private. When you have nurses that have to go to those food banks because of food insecurity, and you have today half of the hospitals in the UK or in England that have installed food donation around them rather than increasing wages. It's crazy. So the perversity of this so-called austerity, we have to understand the outcomes or consequences. Well, what's the solution? They don't want to increase taxes to whom? They don't want to increase taxes to those that can pay taxes. What we call neoliberalism is more than present. It is the fundament of this circular thing that degrades, deteriorates, and leads to a drop of well-being indicators. In a rich country like England, with this, colonial past, well, my colleagues allow me, that is inexplicable how such thing is actually happening. Well, here we have to understand how this thing happens, not only of people seeking the private. Kate hasn't said, or you haven't told me if today families that spend out of pocket with surgeries, treatment, if they can have an income tax deduction. Can they deduct that from their income tax? I don't know. They cannot. But when they can, things are going quite far, as in the US. Because somewhere this has to happen. So I just like to make this comment because things are absolutely integrated and interrelated. And what's most serious is that this idea that the reform was to ensure integral and universal services, this is not true, because what we actually have is a very high level of exclusion for all the reasons that have been already mentioned here. We're going to have a second round of questions. We have Ana Brito. I'm going to ask in Portuguese. I'd like to thank you for the presentation. It's been excellent. I have a question because I don't know very much the health system. I work with water privatization in England. I know a bit about that. I'd like to know who regulates the system, because as to water, you have a national regulatory agency. Who is the regulator? How does it work? What are the problems of this national regulation? I'm thinking very much about us in Brazil. We have a national health agency totally controlled by the private sector, by their interests. So we have a new government and a new administration. We have a PT or labor administration, and the capture continues. I'd like to understand a bit how the regulation works, and the system seems to be very much subject to judicializations, legal actions against for lack of service, malpractice, etc. Who addresses these topics? First question. And the second question is whether there are user associations, social movements, any kind of, organization to discuss. Well, there are strikes of workers, organized civil society. How is it represented considering this privatization and financialization of the services?
Portuguese, okay? Kate, professora Kate.
Kate, comparing the financialization process at first sight in Brazil and the UK. The first observation that I'd like to make and ask actually is that it seems that that financialization in the UK is under, let's say, the service providing and not intermediation of financing, which would be the private health service plans. Is because in Brazil, I assume you know about it, we have simultaneously present in the system the British model and the US model. So simultaneously to the social security system of the health system or the unique health system, where you have a market of health plans or private hospital of diagnostic care that works through tax and subsidies following the US model. So the first question is the financialization in the British case is very much on the hospital private sector and also on primary care when there is the move the GPs to the true trusts that are commercialized, internationalized. If this is true, Lena, it is interesting because the end of public-private partnerships at first sight for a Brazilian health politic analyst, so the state subsidized the growth of the private hospital system, so that from the tax standpoint it was problematic, or from the electoral standpoint, or the standpoint of performance of the health system, and it withdraws when this happens. There is the growth of financialization or internationalization of the British system. This is a question to a certain extent. And the last, there's another one that is important to know how the emerging technologies, the new communication media, information, and facilitate the mercantilization of primary care, and especially the trusts, to the extent that theoretically incorporation of these new technologies could improve productivity, increase the number of scale, number of users that move to private sector, or even price management and risk management of chronic diseases. But the question that I would actually like to ask is, okay, NHS from the standpoint of, from the linguistic standpoint or journalistic standpoint, is a case of permanent public policy. May I deduct from this understanding that from the standpoint of the political electoral cycle, the projects around NHS are fundamental for electoral disputes? Question. At this post-pandemic period, and you make a negative balance in the participation of the state at this moment, in which there is a series of guidance, even in the OECD countries, for a new tax policy, right? UK, when it decided to go for Brexit, may be outside this outline or perspective. Is it possible for NHS at this moment that is post-pandemic, for next elections, be in the core of the electoral scene, which is the case of the SUS in Brazil, although it's different? To what extent there could be a new guidance for the tax policy in the British case? So the health issue, because it is national, because it is something that polarizes society, the British society, for the next elections, it may have implications on the very design of tax and economic policies overall. Thank you very much. Would anybody else like to ask a question? Nobody else? So we can stop now and turn over to you.
Yes, please, you. Obrigada. Ana, eu preciso falar com você depois, tá?
Ah, sorry. Yeah, sure.
So it's working. It's on.
Yes. I've scribbled down on
Yeah, eu acho que eu foi desligado.
this one. Okay, sure. There's a huge disconnect between the reports and plans and what's happening on the ground. It's remarkable. You read all these plans and policies, and then you have in-depth research which finds, as Jasmine presented, the reality is so much worse. And if you know anyone working in this sector, the reality is so much worse. So there's a huge disconnect between the sort of public face and what's happening on the ground. In terms of regulation, there's different organisations. One of the main regulatory bodies is the Care Quality Commission, which looks at organisations providing care and assesses whether they are effective and safe. There's 5 criteria. I can't remember what they are, but one of them is whether they are safe, one is whether they're effective. So they do sort of spot checks on places. And they are publicly funded, and I've spoken to people that work for the Care Quality Commission. And generally, I think they are quite sharp and well intentioned, and I think they do a reasonable job. There's also the General Medical Council, which is sort of a doctors, I think it's medically staffed, that also do regulation. So I think the regulatory function is, it's okay as far as it goes, but I don't know if it actually, you might know more than me, whether it actually regulates the fact that people can't access services, because that's increasingly normalized that you can't get through to your doctor. What I think the general consensus is the care quality is very good. It's the access that's the massive limitation. We still, well, although saying that, but a lot of the indicators that we're talking about, again, it's about access rather than the quality of what's provided. There are quite a few social movements. Keep Our NHS Public is a big social movement. The NHS Federation, huge campaigns. And we've marched to save our NHS. Demonstrations. To what end? I don't know. It was interesting what you were saying. I'm not sure if I've understood what would be a question out of your comments. I've scribbled down lots of notes. Could we have a new tax in the next election? There wasn't there? Oh, just I don't know. There was a talk of a special levy to raise money for the NHS in the wake of COVID, but I think it's just gone. Our political leaders have been in a bit of turmoil, and I think it's. I haven't seen discussion of it since.
Let's say the Labour. What do the Labour say about the NHS situation, and you see if they want to win the next elections in 2024, what do they propose?
But they talk a good talk. They all do. They say we're going to put more money in, but they don't say that it's going to come from increased taxation, because Labour's very worried about doing anything that's going to upset the middle classes. And I'm fairly sure they're not committed to raise.
Do they care about the rich, Labour also?
They care a lot about the rich. They care more about the rich than... There's a lot of discussion about having a wealth tax to fund social services, because that's a clear way that you can raise money in a way that's equitable. And I haven't seen much political appetite for it. There's a lot of campaign groups saying that it's clear that we need more money. But the discussions are very much in terms of increasing efficiency, and you can say about that way that they're going to raise money from charging, what was it, charging people for their visas?
Yeah, I think I can't quite find the details, but I think, yeah, the training plan, the work plan is I think, as I mentioned, it's going to be funded by increasing the amount the overseas visitors pay and that migrant users are forced to pay. So it's, very sort of, it's not about, increasing taxes or taking money from other parts of the budget in sort of redistributing the resources. So it's very problematic. And in fact, I've just found there was, again, I think on Saturday, an article in The Guardian that said 38 million patients wait over 14 days to see a GP in England. So again, yeah. No, and I was checking the article, but there's kind of small local campaigns, and there is this Save the NHS, and in fact, ironically, the People's Health Movement, who I know are active in Brazil, they are active in Scotland, but I don't think there's much activism amongst People's Health Movement in England. And again, there's different NGOs that campaign, like again, the whole issue of migrant access to healthcare, the Refugee Council, and there's a group, Maternity Action. There is a lot of activism around that, and Médecins Sans Frontières, they provide care to migrants in the UK, and there's actually a whole parallel system. Like, one of the things, this doesn't directly answer the question, but one of the things that I think is absolutely fascinating but really awful is that the fact that a lot of these overseas doctors that work in the NHS then have hidden practices that they operate at night that provide care to these undocumented migrants. So I know it's a big issue amongst Brazilians, and particularly, say, Nigerians, who either legally don't have access to the NHS or are led to believe they can't access the NHS. So rather than try and navigate all this kind of bureaucracy, they go to, like, there are a lot of Brazilian churches in London, for example, and they'll go there and someone will recommend a doctor who is a genuine doctor who perhaps by day practices in the NHS and at night or on Sundays has a consulting room in the back of the local hairdressing salon, and they'll go and see the doctor there. And I know these kind of parallel systems. But again, there's not widespread public outcry about this, and there are NGOs that campaign around this, but we talked about this before, but there's a lack of kind of civil society. There are civil society responses, but they're not as active as you would hope. There's a kind of resignation that, well, that's how it is. People have become depoliticized.
I'd like to just comment on one thing here. It's unbelievable to imagine that today in England, access to health, it has become a black market issue, because it's precisely the clinicians who treat people, see people that are migrants who don't have access to the universal NHS system. Therefore, they do this, of course, charging, but virtually illegally. It's unthinkable that you have a process of informalization of health in England, and simultaneously that for the Conservatives, the reason for the degradation, the deterioration of access to health, as Kate says, is the immigrants. They blame the immigrants. It's a far-right discourse. It's not that of the Conservatives. The far right in Europe, as we know, and it's the foreigners. They're the scapegoats that cross the Mediterranean to invade us. We have to eliminate the immigrants because they're taking our jobs. They're making us spend a lot of money on them. And now this new law that's just been enacted in England penalizes even further immigrants. So the point is the following, that you can see that things are moving in a direction where philanthropy is becoming financialized. Virgin is financialized. Is the airplanes now? It's financing mental health, Virgin Healthcare through private equity funds. So there's a financialization of philanthropy. Philanthropy disappears, and it's a private provision, informal, illegal private provision that's making encroachments. So it's the level of perversity and complexity that we have to truly understand what is it possible to imagine that we're going to reclaim in terms of the project for a universal integrated system and health system, because the way things are happening, it's heavily segmented as we can see. It's not just an issue of access, it's segmentation, growing segmentation, which is one of the ways that we're going to have to later finance access through private plans and things like that. Any other questions from the audience here? Okay. You stated that what shocked me was the issue of the waiting line that you discussed. 7,400,000 people on the waiting line, 7.5 million. So the question that came to mind, these people, don't they speak up? These people, don't they say anything on the waiting line? So if there's 7 million people on the waiting line, if they spoke up, I believe the pressure of these 7 million people would make some impact. So the medical teams shout, the nurses shout for numerous different factors, and these 7 millions, don't they have a voice? Don't they speak up? Wouldn't this be a source of pressure for a system that is visibly being questioned and challenged, contested? So I believe that this, who could perhaps do something? People would be these 7 million people on the waiting line, don't have their rights insured, who don't have access to this system, which is not a system which solves their problem. So if I am a user of a system that doesn't serve me and should, I have to speak up. That's my point of departure. That's the point. So when I talked about the local level, it's in this sense that the users, there should be an active voice in the system. They shouldn't be passive. They should be proactive. So I believe that it could, the demand could come from them for the change.
The question is that, and as far as I know, definitely the private health insurance market is growing in UK. And I just checked it, and that's really, and even buying service within NHS trust. So the path of the growth of medical schemes, private medical schemes, is it's following this, the contraction of services. So that's so it's going well. Again, I must stress, it's not the same here because the coverage is different. It's not the same. But anyway, you have the seed, the soil. Good for growth of medical schemes, and all the projections for the next years is almost more than 4% a year of growth of medical schemes in the UK. And at the moment, as far as I know, 11% of the British population, the UK population, is covered by medical scheme. 11%. 11% according to the King's Fund. Private scheme health insurance, 11% according to the King's Fund study. That's a remark. Thank you.
Professora Kate, professora Yasmin, eu tive
I had the opportunity to study with Professor Ted Marmer, I believe, who was a great friend of Professor Rodolph Klein in England. As you know, better than me, they're scholars and researchers who compare health systems globally. On the line indicated by Professor Noronha in front of me, as far as I knew, the private health plan market is limited to more to elderly people without subsidies, but they were limited to the wealthier elderly people, precisely the people that could afford buying on the private market. If I could commit and be so daring as to state from the point of view of public policies which can promote the market. I'm not defending the market. Certainly, if one would implement a scheme for tax waivers, for example, like in the United States, and there's tax write-offs like Australia, Canada, and tax write-offs. Unfortunately, this will allow the growth of the private healthcare market, private health plan market, because it's a way of subsidizing families' expenditures and even of employers in the purchase of private health plans. So, intellectuals in England who defend the NHS cannot allow in any way, shape, or form the introduction of this scheme of indirect expenditures from the point of view of fiscal policy, that this is, so to speak, it's going to be an Achilles heel for the NHS, which already has a number of problems already. And it's going to be the cornerstone for the growth of the private health plans growth, unless you don't have this scheme, because even in financialization, going back to the main theme of the presentations, even in the phase of financialization, I believe that these schemes are the ones that allow this market to continue to grow as a function of that curve and the costs, the growing costs of the Balmore. So without subsidies, even with financialization, the private health care plans is not profitable, precisely because of the pressure from fiscal austerity on the population's income level. So if you have this scheme, so if you would allow me, as a health policy analyst in Brazil, since I've learned from our professors here from the United States and England, that would not allow in any way, don't allow any form of subsidy for the market, because that's going to be the end of the NHS. So thank you very much for the discussion, for your presentations. We are going to turn the floor over to our guest speakers. Another example of the perversity of the system. What characterized neoliberalism and austerity? For example, control over the poor. The poor have to prove that they're poor. You have to prove that I earn very little, that I'm poor. So there's a deduction in the benefits, social benefits. Like in England, for example, you have the child benefit up to 2 children. With the third child, you get the support from the government. In France, you have but in England, they cut it off after the second child, so you have the right. So it's a way of controlling and reforming the system for social benefits. So you have control that's increasingly rigorous ever since the Thatcher government, for you to control and demand that people prove things, that they are looking for jobs and looking for employment. So for people who are working, what do you do with the people that are working? People have earned terrible wages. So just imagine people in nursing, for example, who earn poor wages, and now they need even to live with from food banks to be able to eat, and they're indebted even. In other words, they're increasing their impoverishment. So on the one hand, you push people, workers in the working class, and skilled workers to become poor. On the other hand, you reduce the social benefits and you create more control over poverty. And you have this policy of growing targeting, which reduces the social coverage. So it's a business. So I have to look at this as an integrated way that this thing has, because it's austerity. It hits people from all different sides, and it creates these kind of channels, as I was saying, as Carlos was saying, that lead to the fact that some things end up happening because it's almost like inherent to the very logic of what is encroaching and given this apathy on the part of the population. Because I think that the victory of Thatcher, and I just spent a year in England, I saw it happen. Things, people are going to be tomorrow. Everybody's going to be out in the street demonstrating. Of course, I come from France. I have a French background, where people go out and take to the streets because they cut the king's head off and they beheaded the king. This has an impact on people to this day because they beheaded the king. I'm not saying that you should cut King Charles's head or anything, but that's how things work in practice. But the important thing is the following: it's how this apathy, it's the product of neoliberalism. That's how things are. Thatcher saying that's how there's no alternative. You take it for granted. So they always look for private solutions. This involves the encroachment of private health plans for people who are going to be sacrificed to be able to pay for them. Because on the other hand, so far there's no growth in salaries or anything, but at some time people are going to have to begin to go into debt to pay their bills. So I think that is why I have to look at the complexity, the dynamics inside the social protection system as a whole, which from the labor market all the way to all kinds of social benefits, etc. And this is the issue of care, and the care, which in England, unlike Brazil, it's part of the health system, the social protection system. It's health and care, and we've never been able. And I'd like to say this to our colleagues here from in the health field. I talk a lot about with this Carlos.
We don't understand the importance of associating the question of care, economics to health care, to the high-income people going into these large homes for the elderly. There are property investments like, a farm, hotel. People pay fortunes, and the middle class that gets into debt to be able to keep an elderly person in the family in something that is sort of uh, average Paduco, and plus drugs. Everything is outside. Then you have maids, maid servants, 100,000 of maids in Brazil during the Bolsonaro administration, during the pandemic. They had the attempt of professionalizing, well, actually turning the profession, those that caregivers to elderly, giving them a wage level, and that was rejected by Bolsonaro. It was approved in Congress, and he rejected that. So today there is no job or profession of caregiver. Therefore, I have a domestic employment or household employment. So we have to think about the urgency of the colleagues in the health system to incorporate this dimension. This is a great bottleneck, and we see a strong segmentation, but expelling to the private sector the caring for people that grow old. And of course, we will have an increase in the private healthcare provision from 2050. From the standpoint of demographics, almost 30% of the population over 60. So that will be, in fact, well, the expectations of heavens for the private equities, because for anything, there are property like Orpef. It was a French company that during the pandemic, they discovered that the mortality rates within their homes is the largest multinational group of home care for the elderly in private units. And it was found is that people was very poorly treated. They were starving, and there was a huge report by a journalist, and the government decided to investigate. They shut down there, and they opened here in Sao Paulo. That's it. Thank you.
Yeah, I just picking up on some of Lena's comments and your question. I think part of the issue as well is that, as has happened in Latin America and elsewhere, there's been a kind of, over the past few decades, this reframing of public discourses and this acceptance of the role of the private sector that we kind of feel it's inevitable. And there's a survey again that was conducted last month to celebrate the 75th anniversary of the NHS. And it states, or it finds that, and this was a nationwide survey, that 7 in 10 people believe that it's inevitable that we'll have to, that parts of the NHS will be provided, that we'll have to pay to use the NHS. It will no longer be free at the point of delivery. And that 66% of Tory voters, so right-wing voters, felt it was more likely that we should have to pay user charges compared to only 51% of left-wing voters. So again, this is both sides of the political spectrum, and that the majority, 80% of those surveyed, think that the NHS needs an increase in funding, but only 31% of those surveyed thought it should come from a dedicated NHS tax. Only 22% thought it should come from national insurance, so paid for by, deductions from former workers' pay packets, and only 21% thought it should come from an increase in income tax. So while people believe that more funding is needed, there's a reluctance that we should, pay for it through taxation, and there seems to be a kind of acceptability that we are going to have to pay for services, and that's, yeah.
Thank you. But just a few points. I think we have a massive lack of accountability. I was thinking about what you were saying about the NHS waiting lists long, and it's despite government pledge. So the government says it will do something, and it doesn't. And well, I guess this is a universal problem. They promise to do things, they don't, and there's no comeback. Just on what Lena was saying, I heard one of our government ministers on the radio last week saying the problem with migrants coming to the UK is that we can't afford to give them public services. So there's a very strong narrative being pushed. This is on the BBC radio by a government minister, that we don't have public services because we have too many migrants coming to the country. I mean, how can that be allowed? That they can? We've shown the cuts in funding, the decimation of the health service, and then we blame migrants. Unbelievable. There's no interest really in the fact that these companies are taken over by private equity either. In social care, there's a big problem with private equity, financial investors using financial engineering to extract revenue. We're losing our NHS funding to the murky owners of the Priory providing mental health services to vulnerable people. But nobody really cares. The only regulatory issue is in case they collapse, because if they become so indebted that they collapse, then we'll be in trouble because we can't live without them. So we don't care about social equity in this issue. We only really care if they're going to collapse. And even if they are going to collapse, the regulatory framework is only designed so that the local authority can make plans to deal with the collapse. So this asset stripping, nobody is bothered by that, only if it means we have to think about how we organise our services around a collapse. So nobody's really that bothered about the big dramas. the way our system is being stripped by finance. I think that's a great idea about mobilizing the 7 million on the waiting list. But we do have a lot of apathy. What tends to happen is these people are targets for companies offering private services, and then they'll offer you a financial plan, you'll disappear off the waiting list. Everyone's happy because the waiting list goes down, the private company's happy, you're paying thousands of pounds, but it's better than the alternative possibly. So these are the ways that it's being eroded, and everybody says how terrible the NHS is. Even more reason that we don't want to fund it. I'm not surprised that private insurance is increasing, and I think it's shot up a lot since COVID. It's much more common to talk about private insurance and it wasn't for a long time. Mostly people with jobs would get private insurance with their jobs, but generally for an individual to actively take out an insurance plan was rare, but it's becoming more common now, particularly with the narrative that the NHS is failing. We need to do something individually about that. I will take out insurance so that my family is covered. Obviously, hugely problematic. So I wasn't really aware of this idea that if you pay private insurance, then you have a deduction of what you pay on your tax. Is it so? Yeah, okay. Right, okay, okay. Right. Oh, that's, yeah.
But in the US you have a cap, not in Brazil. So far we don't have a cap.
So if you pay...
We can deduct everything from our income declaration.
What you pay for private medical facilities. I mean, that is a strong narrative. People are saying, why should I pay my tax bill if I'm not able to access, especially if I have to see someone privately to have my surgery? I shouldn't be paying. And yes, I think that would be a very bad thing if that continues in the UK. I didn't realize that was how things were managed here. So, right, that's something to add to our list to make sure it doesn't happen. But I mean, as Lena pointed out, we're seeing a rising tide of very punitive decimation of our welfare system. It's not just the NHS, but schools have been stripped as well. We're seeing people having to do more with less, staff burnout happening across our central services. It's a very hostile environment for poor households, and particularly across people with disabilities, and there's racial and gender divides as well. And the health sector reflects this. But I think also we have, as academics, to dismantle this argument that we need the private sector because the public isn't working. Like, we pay anyway. We pay tax, we pay insurance. It doesn't solve anything if you're paying someone private. It just makes it cost more, really, because you have the duplication. So, yeah, it's happening a lot in the UK. What Jasmine was saying, people saying we need to pay our GP when we go to the doctor, but tax people more. It's much fairer if you're taking money from rich people than if you're taking money from sick people. I'm sure you will know this, but this argument comes up so often. We need the private sector because we can't afford the NHS. It's absolutely wrong. We're paying for the private sector. We would be better off funding a public system. So I think we need to just get that out into the mainstream so that these crazy arguments of needing the private sector can go away.
Bem, eu quero agradecer muito a todos.
I'd like to thank everyone. It is almost 1 p.m., the time limit for our session today. I'd like to thank everyone for your presence. Thank Kate and Jasmine for being with us. I hope we can be in touch and exchange more information and also experiences and think about strategies, because certainly those groups behind financialization are those that act upon all over the world, not just here and there. They're the same always. I'd like to once again thank very much on behalf of Professor Prince to all institutions that have joined us to make this debate possible today. And I do hope we can do more things in common together, share and exchange ideas, and think how we also in Brazil are going to face the forthcoming years, which are going to be quite tough. So thank you all very much indeed.